Unfortunately, over the next few months, Mr. Smith gradually becomes frailer and less active and has a series of chest and urinary tract infections. His mobility continues to deteriorate and he spends most of his time in bed. His niece and carers have noticed that he does not recover as fully or as quickly as he used to. He is less interested in his food, taking only a small diet, and has lost weight. He's often incontinent. His ability to engage in meaningful communication has become limited. Mr. Smith hates being in hospital as the staff and the surroundings are very unfamiliar to him. The hospice at home and district nurse team step up their level of support, visiting at least daily to review Mr. Smith. They provide practical advice, hands-on care, and administer medication needed to alleviate his symptoms. Alongside the GP, they also provide support for his niece and the care home staff.
The GP visits and discusses the situation with Mr. Smith's niece and staff. She discusses his progress and current situation at the Practice Gold Standards Framework, or GSF meeting, as she is concerned that Mr. Smith may die in the next few weeks. It's important the right preparations are made to support Mr. Smith, the care home and his family. It is agreed that he should be placed on the GSF Palliative Care Register. This is a register of patients who are possibly in the last year or so of life who are discussed at regular surgery multidisciplinary meetings. These are typically attended by GPs, district nurses, hospice community specialist nurses, community mental health nurses and any other relevant providers of health and social care in the community. Patients are monitored for the need to step up their care provision when required. Following the GSF meeting, it was agreed that the district nurses and local community specialist palliative care nurse would also become involved in Mr. Smith's care to provide additional support and expertise.
Hello, hi.
Kim and the GP meet Maureen to plan Mr. Smith's care as he approaches the end of his life.
Yeah. Marvellous. Hi, Kim. Right, thank you for meeting up. I think it's going to be very helpful just to have a think about how Jack is and talk with you and with Kim about how we carry on with continuing with his care.
Right.
That's all right.
Yeah, absolutely.
Okay. It'd be helpful to start off with just if you could sort of tell me a little bit about how you think Jack is at the minute.
Well, yeah, I know he's not going to get any better, but I think we have. I mean, I've said to Kim, I have been a bit worried actually about his. Particularly over the last couple of weeks, he seems to have deteriorated quite a bit.
And his physical health has gone down. He's not eating.
Yeah.
He's very reluctant to drink as well. We've been spending a lot of time with him trying to encourage him to have drinks.
Okay.
Obviously he doesn't want to get out of bed. He's quite poorly, really.
He's not. Yeah.
I mean, it helps me enormously to hear that. Certainly, the last few times I've been in to see him, I can see that he's changing each time. He's less well every time I come in. And I think this meeting's come at a really useful time because we need to think about how best we continue to care for Jack and for you. Well, I think that I can see he's less well and we need to focus on all the right treatments and the care and support that are going to be helpful for him and ensure his comfort and dignity.
I'm not absolutely sure I'm following you.
Yeah. Okay. When Jack was well, did he ever share with you, ever have any conversations with you about how he might feel about treatments or things that were important to him should he become unwell?
Not really. He's not that kind of man. Yeah. You know. I mean, I think he always says he doesn't like fuss, does he?
He doesn't like. He's a very how shall I say, independent man. He doesn't want people to fuss around him.
Okay.
But he's not. He wouldn't have that kind of.
Yeah. And I'm aware that the last sort of couple of hospital admissions particularly
he doesn't like being in hospital.
have been quite distressing for him.
Yeah.
The reason I'm sort of just exploring this with you is because I am concerned that he is less well, that he's changing, and that we may actually be looking perhaps at him approaching the end of life, or that last bit of life.
I don't think he was. I mean, do you mean he's dying, or I mean, I don't think he was that bad.
He has been quite poorly for the last month or so. He's been going downhill. I mean, he doesn't want to eat. I mean, we're struggling to sort of making him have his drinks, and especially fluid.
I think it's always difficult to know exactly, as a doctor or a nurse, when we're trying to think about someone's prognosis, how long they might have. It's hard to be exact about that. But we often have to look backwards and look at how someone's changing, that he's eating and drinking less, in bed, sleeping more. These are all things that indicate to us that he may be approaching the end of life. Looking at him today, I don't think we're in that hours or days bit, but I do wonder if that we might be looking more at some weeks, a handful of weeks. I can't see him going on a long time with how poorly he is at the moment and how poorly he's been. What's important, it's very hard having this discussion, I know, and I'm sorry that it's upsetting. It's very helpful and important, though, that we talk about these things, because it helps us to ensure the focus of his care is about ensuring his comfort, his dignity, and we can begin to explore what are the treatments that we will offer him. Because
so you will still treat him?
Absolutely. Acknowledging that someone's becoming less well is not saying that's it, there's nothing more that can be done, that we are abandoning someone. It's about recognising that that time's coming and actually stepping up the care and perhaps involving more people. We might need to involve our local hospice colleagues.
So he doesn't have to go into hospital, because he hates. He really
Yes.
he hates hospital, and I mean you've seen him. He's really been.
He hates. Yeah, this is his home. He's sort of
And he likes the
knows all
people
of us.
here,
He knows
and
the
he-
people
yeah.
here. I mean, obviously we will look after him, as best as we can, with the help of other nurses and doctors and GPs. It's part of a team. We're a team. We work together.
It's right that he stays here, and Kim is absolutely correct.
Because he likes it here.
There is other support we can bring in, as I mentioned,
Yes.
district nurses, hospice nurses, to help us look after him, and we all work together. The focus is on what treatments will help him. So let's say he got another chest infection. If he felt able and well enough to take some antibiotic syrup, we would offer him that.
So you wouldn't just let him die?
No, we won't. No, we will treat him and make him comfortable as best we can.
The treatments that are helpful in this situation are treatments that help to relieve symptoms. So let's say he got some pain, we can give him painkillers. If he was chesty, we could give him medicines to help with his chest. If he was feeling frightened or anxious, we can give medicines to help with that. If he is unable to take medicines by mouth, we can also give those sorts of medicines through by other means, and we often use something called a syringe pump to give medicines to people when they're perhaps at the very end of life. There is one very specific treatment I just need to talk with you about if you feel able to.
Yes.
It's a treatment called resuscitation. CPR is its other name. It's a medical treatment that is given sometimes to people if their heart stops. Now, it's a treatment that involves, as you know, pressing up and down on people's chests, maybe helping to breathe for them by tubes and squeezy bags, and sometimes electric shock treatments, maybe even going to hospital. Now,
I don't think he wants to go to hospital again.
Well, I share that sentiment.
Yeah.
I think the reason I specifically have brought up this treatment is that it is a treatment that it helps some people, but not everybody. And I think for Jack, the chance of that treatment working and being helpful are really very small. And actually I think it would be very distressing for him, potentially for you all, to approach that treatment for him. I actually think it would be an unhelpful thing to do. And I want to protect him from a treatment like that because I think it might do more harm than good. Maureen, it feels like we're covering a lot of things, isn't it? But it's good stuff. We're putting together a good plan, I think, for Jack. To me, the key thing is about making sure that things are in place to enable Jack to stay here.
Yeah.
There are a lot of things that a healthcare team can do working together to make sure that the end of Jack's life is as good as it can be. A hospice at home team, district nurses, GPs work together and should talk with patients when they can, with their families and with those who are looking after them. And in many areas now, there's a system by which just in case medication can be prescribed and dispensed and kept in the home, so that if Jack should develop problems all of a sudden, especially out of hours, the medication's there so that we can address it straight away.
What also helps, if you're happy with this, is it's useful to document. You know, we've spent a long time, haven't we, just going through what are the right things to do and helpful things to do for Jack, to document our discussion. And there is a form that I can use, that I can fill out, where I can write down the decisions we've made today, what's important. On that form I can also make it very clear that it's would be Jack's wish and your wish that he stays here.
And can I look at that?
You can,
Yeah.
and actually I would like you to look at it and just check it through and make sure you're happy with it, because it's my responsibility to fill it out, it's as a result of our discussion today. The beauty of this form is that if a doctor or a nurse or our hospice nurses, local hospice nurses came in, the form is there in this folder. Kim can keep it in this folder.
I keep it in the folder, yeah.
And you don't have to go through all this again.
Also, most areas now have an electronic database for the out-of-hours team, updated by the healthcare team. If there is a written plan in place that's been agreed with the family and the healthcare team and the carers, the out-of-hours doctors will see on this database that it is there, and they'll know what decisions have been made. So that communication is really important, so that the right thing happens if there's a call out of hours.
Right.
And as GPs we use that register a lot, and it's very helpful.
And would you like me to inform you if things happens, you know, as we go along?
Oh yeah. No, I do. I mean, I don't want to have to keep telling people the same thing, but I do want to know what's going on. Yeah.
Okay, all right.
Yeah.
I'll do that.
And we would keep you informed. You know, if I continue to see that Jack is changing, we will keep you informed. And if we can see that he is perhaps approaching the last week or so of life, you know, we will talk that through with you, and we will support you with that.
Also, I don't want to not be around.
Yes.
If anything happens.
Yes. Yeah.
Yeah.
And
We'll keep in touch all the time. I'll keep in touch with you all the time.
Okay.
All right. And you can ring me anytime, you know, even though it's night time. If you feel that, you know, you're worried, you know, give us a call. We're here all the time.
That's really important.
Okay. So, anything you want to know, I'm always here. You can always, you know, have a chat with me. And if I don't know, I'll.
Oh yeah, no, I know, because you know, Kim's been great. Yeah.
We've covered a lot. Is there anything that we haven't talked about, or any questions, anything that doesn't make sense?
No, I think I just need to go and think about all of this a bit.
Okay.
And read your thing when you know, and just yeah, and maybe you know, I might need to have another chat.
Of course, yeah. And thank you. I appreciate it's been a long
hard.
discussion. It's hard, but really helpful and really beneficial for Jack. I'd quite quite like to pop in and see him now before I go back to surgery. Shall we pop in together?
Yeah.
Okay.
Yeah, I think that's a good idea.
Mr. Smith further deteriorates and his niece is able to spend more time with him. The care home staff continue to be supported by the GP, district nurses and hospice community team. He develops another chest infection, but despite managing a couple of days of oral antibiotics to help with his cough, he becomes less well. He's no longer able to manage any medication or sips of fluid. He's chesty and at times agitated. The team all agree that he is likely to be in the last few days of life. The GP and carer talk this through with Mr. Smith's niece. She is not surprised, having seen her uncle's condition change more rapidly from day to day.
The hospice at home and district nurse team step up their level of support, visiting at least daily to review Mr. Smith. They provide practical advice, hands-on care and administer medication needed to alleviate his symptoms. Alongside the GP, they also provide support for his niece and the care home staff.
Is that all right, Maureen? We thought he was quite comfortable on his medication, but he's not able to swallow it anymore.
No,
and this just takes the worry away.
He's getting quite distressed from time to time.
Yeah. We can increase it if we need to, but at the moment it seemed to be enough. So this just takes the worry of trying to get it down him. Is that okay?
All right. You do whatever.
Okay.
I love you, Jack.
Sadly, Mr. Smith passed away 3 days later, but he was peaceful and Maureen was with him. The staff at the care home felt pleased and privileged to have been able to care for him right through to the end of his journey.